Good afternoon, everyone. iTech India welcomes all the participants for today's regional distance learning seminar session. Today's topic is management of ARV toxicities, and the speaker is Dr. Sonali Salvi. Dr. Sonali Salvi is the Associate Professor and Unit Head at the Department of Medicine, BJ Medical College, Pune. She has completed training and courses in PGDGM, Clinical Management of HIV, Comprehensive Hemophilia Management, and Evidence-Based Diabetes Management. She is also a member of SASIP at BJMC, Pune. We welcome you, ma'am, for today's session and request you to start the session.
Yes, so I hope I'm audible to all, and it's indeed a very good afternoon. So let's straight away start with the topic. So today we are going to discuss the management of antiretroviral toxicities. So the session. Hello,
ma'am, can you switch to full screen mode, please?
Yeah.
Yes, ma'am.
So today we are going to deal with the antiretroviral drug toxicities. So in the session objectives will be introduction, dolutegravir toxicity, grading of drug toxicities, drug substitution, guidance in impaired renal function. So first, let's see how do we manage the ARV toxicities. So in the introductory slide, we'll see how the drug toxicities to the first line class specific and or drug specific, and ranging from low grade intolerance, which may be self-limiting, to life-threatening adverse reactions. The toxicities need to be differentiated from complications of HIV. Now, how do we say that this is a drug toxicity or this is a complication of HIV? So, for example, patient who is started on tenofovir can develop impairment in the renal functions. That is evident by rise in serum creatinine. Sometimes HIV-induced nephropathy also can present similarly. So it is always essential that we differentiate whether it is a tenofovir-induced toxicity or it is a HIV-induced nephropathy. So sometimes it is not possible to differentiate. Hence, we first eliminate the drug which has caused this toxicity. So we have to remove that drug, offending drug, and introduce a drug which has lesser chance to have renal toxicity. So this is just an example. There are many such examples where you need to do it. Manifestations of a new OI. So new opportunistic infection may just rise in, and that may mimic that is as if a drug toxicity has happened. IRIS, you're all aware of IRIS, immune reconstitution inflammatory syndrome, and you're also aware that rise in CD4 has to be documented to label it as IRIS. And once the patient has been started on antiretroviral therapy, either it could be a paradoxical type of IRIS or it could be a unmasking type of IRIS. One has to also take into consideration the comorbid conditions. For example, in the earlier example of tenofovir toxicity, what we have discussed, it may happen that a patient may be diabetic, and patient as a complication of long-standing diabetes may develop diabetes and diabetic neuropathy. So diabetic nephropathy, neuropathy, these are all complications of the condition per se, and we have to differentiate these from the drug toxicities. So once we admit the patients or we carry out certain investigations, it becomes evident that this is nothing but the complication of the disease per se. Also, concomitant medications. So concomitant medications have to be seen, like for example, in case of nephrotoxicity, if the patient is on LES regimen, that is levofloxacin ethambutol streptomycin regimen of anti-tuberculous therapy. So in that case, streptomycin per se also can produce nephrotoxicity, which has to be differentiated. So you have to consider all these possibilities once you label a person to be having a drug toxicity. So we can classify the ARV drug toxicities as NSRTs, which are zidovudine, stavudine, lamivudine, nucleotide reverse transcriptase inhibitors, which are tenofovir, integrase inhibitors, which is dolutegravir and raltegravir, and non-nucleoside reverse transcriptase inhibitors, which are efavirenz and nevirapine. So zidovudine, stavudine has been phased out, but still you will see some patients who have had prolonged exposure of stavudine. So that is why stavudine has been mentioned here. So these are chronic toxicities, so you will have to slightly know about them. And then you have lamivudine, which is an integral component of the first line and as second line as well as the third line regimen. So mitochondrial toxicities are lactic acidosis, pancreatitis, lipodystrophy, hepatic steatosis, peripheral neuropathy, anemia, myopathy. Tenofovir, nephrotoxicity as well as bone toxicity. So bone toxicity has not been mentioned here, but bone toxicity also is a feature of tenofovir. Dolutegravir and raltegravir, they produce weight gain, hepatotoxicity, and allergic reaction. Whereas efavirenz and nevirapine, they have skin rash, hepatitis, central nervous system manifestations. Now, this both these drugs have equal propensity to produce skin rash. Nevirapine especially produces hepatitis to a greater extent, and nevirapine toxicity has been very closely linked to the gender. That is, female sex has been associated with toxicity. So there is genetic basis to it, and more or the less, we have almost brought the use of these drugs to minimal. Now only few patients are on zidovudine, lamivudine, nevirapine therapy, and mostly the patients are being switched on to a dolutegravir based therapy. So tenofovir produces, now these are adverse drug effects of NRTS. We'll discuss them individually. So tenofovir produces renal toxicity, bone demineralization. Zidovudine produces anemia, neutropenia, bone marrow suppression, gastrointestinal intolerance, headache, insomnia, myopathy, lactic acidosis, hyperpigmentation of skin and nail. Whereas lamivudine, it produces minimal toxicity and rashes. Rashes are due to lamivudine, we have seen from grade 1 to grade 4. And some patients we have seen even with angioedema, but then these are of extremely rare occurrence. Grade 1 and grade 2 rashes are very common and they are easily dealt with. We have seen several cases who have, with continued use, they have developed minimal toxicity. In some cases, we were really able to manage with antihistaminics alone. Abacavir produces hypersensitivity reaction in 3 to 5% cases and it can be fatal. Fever, rash, fatigue, nausea, vomiting, anorexia, respiratory symptoms, sore throat, cough, shortness of breath, and re-challenging after reaction can be fatal. So abacavir, as we all know that the hypersensitivity is genetically linked because of the presence of HLA-B5701 gene. It is associated with less than 5% of adults and children in India, and hypersensitivity usually occurs during the first 6 weeks of therapy. Some patients we have seen that it can occur at any point of time, but whenever it is noticed, it has to be discontinued immediately. So there are some questions which have been frequently asked regarding this, is that do we test each and every patient? So ideally in our resource limited settings, it is not possible to test each and every patient for HLA-B5701. However, if some patients are willing or if there is feasibility, then this test can be carried out. Or if the patient has had earlier drug toxicities to say some commonly used drugs, then this drug needs, we need to be make sure that the patient doesn't carry this gene. Otherwise, in all other cases, abacavir can be initiated, and a close watch on the patient has to be kept till at least 6 to 8 weeks, so that they develop early indicators and they can report to you where you can stop the drug. Though we have mentioned only fever, rash, and respiratory symptoms, we have seen patients presenting with diarrhea as well. So intractable diarrhea has also been one of the features we have observed in clinical practice. And once you see any of these, you can suspect that it could be an abacavir toxicity. And before it worsens, you can stop the drug. And most of the cases, the symptoms revert after stopping the drug. Efavirenz produces central nervous system symptoms, dizziness, somnolence, insomnia, confusion, hallucinations, agitation, and personality change. Rash occurs, but very less common with nevirapine, and avoid taking efavirenz after heavy fatty meals. So usually these central nervous symptoms are quite distracting to occupations which involve night work. For example, if the patient is a healthcare worker, if the patient is a security guard who needs to be awake during night time, or if the patient is in some emergency services like fire brigade or transportation services. In such cases where night work is involved, patient can land up with serious life-threatening complications. And so occupation of the patient has also to be considered when you are taking history of the patient. And as soon as patient reports these symptoms, the assessment has to be made by the doctor whether continuation of the drug is likely to benefit or cause more trouble to the patient. Nevirapine. One more thing about efavirenz is there are patients who report of suicidal ideation. That is the most important indication where the drug has to be stopped immediately, because suicidal ideation is one thing where patients it is a extreme form of depression in which the patients straight away go and commit suicide without letting anyone know. So as soon as you get the first idea or the first symptom related to this, you have to stop the drugs. Now, nevirapine produces hepatitis usually within 12 weeks, sometimes life-threatening hepatic toxicity. Now, lead-in dose is one thing which has been introduced, keeping into view about this fact, which you all have practiced earlier. Now, I don't think you will be practicing this because nevirapine is not in the new schedule, but still you should keep into your mind that those patients who are still on continuing on, say, example, ZLN therapy or TLN therapy, if patient develops hepatitis, then this drug has to be immediately discontinued. Skin rash occasionally progressing to severe conditions, including Stevens-Johnson syndrome and toxic epidermal necrolysis. Patients who develop severe hepatic toxicity or grade 4 rashes while being treated on nevirapine should never be rechallenged. And in fact, in females also, any grade of the toxicity, you should never rechallenge with nevirapine. Atazanavir, ritonavir, this is again a drug which you have most commonly used. Hyperbilirubinemia and less lipid problems than with lopinavir. Hyperglycemia, fat maldistribution, nephrolithiasis, and sometimes electrocardiographic abnormalities. You can get sometimes QT prolongation, and also drug interaction. So in example, for if the patient is a case of hemophilia, and patient can have excess bleeding if the patient is on atazanavir ritonavir combination. And lopinavir ritonavir is a heat stable tablet, and mostly diarrhea, nausea, vomiting. These are the three important complaints which most of the patients develop. Now you might wonder with the extended use of atazanavir, what is the role of lopinavir? But lopinavir is still in use because most of our patients who are being diagnosed with HIV-2 are still on lopinavir based therapy, and even in some pediatric patients who have multiple drug related issues, this drug is being continued. So PS should not be prescribed with simvastatin, as they significantly decrease the level of simvastatin, leading to rhabdomyolysis. In fact, with every, in most of the cases where protease inhibitors develop increase in the lipid levels, protease inhibitor induced hyperlipidemia should be considered, and these patients should receive treatment, because then otherwise they will land up with the complications like stroke and myocardial infarction. So that is why you have to be really cautious in diagnosis of hypercholesterolemia at the right time, so that these complications are avoided. But at the same time, you should also keep a close watch on patient's complaints. That is, if the patient complains of muscle cramps, especially patient says, I am getting fatigued or I am getting cramps after walking, then these are the features where you should suspect that there could be a underlying rhabdomyolysis going on, and creatine phosphokinase is the level has to be estimated, so that one gets an idea whether early toxicity of the statins has set in, and in such cases immediately statins should be withdrawn. Now, dolutegravir. Dolutegravir, you know that most ever since dolutegravir has been rolled out, most of our patients have been shifted on DPG based regimen. So hepatotoxicity, weight gain, allergic reactions, and insomnia. So hepatotoxicity has been closely observed. Some of you must have seen in your clinical practice. But rest of the things are not like very evident. This will be, I am sure these will be evident with due course of time, and with the increased use of dolutegravir, one will come across more such cases. Dolutegravir produces hepatotoxicity, allergic reactions, and myalgia, rhabdomyolysis, myopathy when used concomitantly with other drugs, increasing the risk, and severe skin rashes and hypersensitivity reactions have been seen in a few patients. Now, raltegravir has been a part of third line therapy till few years. And so you have to be also aware that some of your patients will be on raltegravir plus darunavir therapy. And in such patients, if they develop hepatotoxicity, raltegravir should be the culprit and should be considered. The dosing should be considered, and you should make the necessary changes once you suspect any signs of hepatotoxicity. Now, short-term toxicities, and we can also divide the toxicities into short-term, medium, and long-term. Now, what is the importance of knowing the short-term toxicities is in some patients we have seen loss to follow-up. So some patients get lost to follow-up from your therapy. They are non-adherent because of these simple side effects which can be treated. I have often seen that patients develop severe nausea and vomiting to zidovudine therapy, and sometimes even diarrhea, which is intractable. And these patients usually don't report, and they say that we are not able to tolerate this drug, and so kindly or they do not even turn up to show you, and they say that I cannot tolerate such drugs and I'm going to stop taking them. So you should always be careful and call the patient whenever you start any patient on antiretroviral therapy. The earlier follow-up, the first follow-up should be usually 1 or 2 weeks, where you can really assess these toxicities. Now, bone marrow suppression also has been seen with an acute onset. Now, how this patient is likely to present? The patient is likely to present as severe anemia, requiring blood transfusion. Some patients have presented like pancytopenia, thrombocytopenia with bleeding manifestations, and all these has happened very rapidly. So silovudine should be immediately discontinued, and in any person who has had severe toxicity or has developed condition or severe anemia that leads to blood transfusion, in such patients, zidovudine should never be reintroduced. That should be the dictum. Then in medium-term toxicity, we have bone marrow suppression, anemia, hyperpigmentation, lactic acidosis, and proximal myopathy. Now, out of this, hyperpigmentation is very well evident, and most of the patients who have cosmetic disfigurement will come to you very early in the course of time. Lactic acidosis, clinical suspicion is very difficult, but there is some subset of symptoms which I am going to be telling you now. Those symptoms, if they occur, you have to be vigilant. Like, for example, nausea, vomiting, leg cramps, and in late stages, when the lactic acidosis becomes very severe, they present with dyspnea. Okay, so these patients are usually tachypnic, and once you do that arterial blood gases estimation, the lactic acidosis is evident, and lactic acid level is more than 2 in almost all patients in whom lactic acidosis has been suspected. Proximal myopathy is one condition where the muscles are affected. Commonest complaint given by the patient is difficulty in getting up, or difficulty in holding two objects which are at a height, or difficulty in fetching objects which are situated at some height or some distant place. So wherever proximal muscles are being used, these patients also have difficulty in climbing the stairs. So while they go upstairs, they say that I am not able to lift my foot rapidly, or I get very much fatigued when I climb 2 or 3 flights of stairs. So these are the complaints which the patient will tell you, and you have to be very proactive in diagnosing these. If you do not pay attention to these complaints, or if you do not give importance to these complaints, then it is likely that the toxicity is going to worsen. So long-term toxicities, because the long-term toxicities are usually an extension of these. So what I have seen in the clinical practice is anemia is missed, because say for example, patient has developed anemia, patient will be experiencing exertional fatigue, but has not come up to the center, or some proxy person is coming to take the medication. So make sure that patients on ZLN at least undergo hemoglobin testing every 3 months, so that you call the patient to the clinic, ART clinic, and get his hemoglobin tested, so that you find out that the anemia is severe or at least moderate, and then you can initiate treatment early. Lamivudine is short-term toxicity, skin rash, and there are virtually no known long-term toxicities or medium-term toxicities with lamivudine. Stavudine, we have seen some cases of lactic acidosis, but virtually not very acutely, but they present as medium-term toxicity. Pancreatitis and peripheral neuritis are also medium-term toxicities. And lipodystrophy and dyslipidemia are long-term toxicities and which require attention and treatment immediately. So then you have abacavir. Abacavir, as we already discussed, the hypersensitivity reaction can be very fatal, and in adults especially, the hypersensitivity manifests very rapidly. So you have to be careful while the patient is on abacavir, especially adult patients. Now, integrase inhibitors, dolutegravir, we have nausea, diarrhea, insomnia, rashes, and hepatotoxicity. So these can occur early in the course of treatment or as a medium-term toxicity. That means first week itself they can present with, or first 1 or 2 months they can present. But dolutegravir long-term toxicity is still under study. There are a lot of studies which are being conducted and which are focusing towards the glycemic control. We are yet to get data on the long-term toxicities. It has been rolled out the latest. It is the latest drug in the HIV anti-HIV drug armamentarium. So that is why we are yet to get the long-term toxicity details. And I'm sure some studies will come up so that we know what are the long-term metabolic toxicities. Raltegravir produces nausea, diarrhea, insomnia, rashes, and hepatotoxicity. In the clinical practice, we have seen raltegravir as a very well-tolerated drug. Then efavirenz, you have drowsiness, dizziness, confusion, vivid dreams, skin rashes, hepatotoxicity, and medium-term toxicities and long-term toxicities are virtually none. Nevirapine produces skin rashes and hepatotoxicity and almost no long-term toxicities. Now, overlapping toxicities. What is this concept of overlapping toxicities? Now, once the person is on multiple drugs, for example, a person may be on antiretroviral therapy as well as some anti-malarial drug or some anti-leprosy drug. In these cases, you have to be really cautious because when you're using two drugs, that both the drug toxicities can occur simultaneously, and it becomes very difficult to point out one particular drug. For example, bone marrow suppression can be produced by zidovudine, cotrimoxazole, dapsone, pyrimethamine, ganciclovir, amphotericin B, ribavirin. So, for example, if the patient who is a PLHIV develops, say, CMV infection, so CMV esophagitis or CMV related any infection, the patient is likely to be on ganciclovir and zidovudine at the same time, and then you see that the patient has developed pancytopenia, that is HB and WBC count have all reduced, and then this is an example of overlapping toxicities. Commonest example is amphotericin B with zidovudine, when patients usually present with systemic fungal infections like mucormycosis or your aspergillus infection. So in these cases, bone marrow suppression can occur. Hepatotoxicity is produced by nevirapine, atazanavir, lopinavir, ritonavir, isoniazid, rifampicin, pyrazinamide, fluconazole, cotrimoxazole, and dolutegravir. Peripheral neuropathy is produced by stavudine and isoniazid. Isoniazid-induced peripheral toxicity is again very common entity, and I'm sure most of the experienced doctors will be able to diagnose it very early. Stavudine, as such, we are not using it now, but maybe patients who have had exposure to stavudine early on in their course of treatment. These are the patients who have already had stavudine-induced neurotoxicity, and isoniazid is likely to worsen it. In pancreatitis, stavudine and cotrimoxazole. So cotrimoxazole also can precipitate pancreatitis, and one has to be really cautious in use of this drug. So now let's see the toxicity of dolutegravir. It is a preferred first-line drug in India for all the new patients to be enrolled. It has a good overall safety profile, fewer metabolic side effects, minor side effects like insomnia, GI tolerance, and skin rashes. and usually raised concerns are neural tube defects in the fetus when used in pregnancy. We will be dealing with this aspect in the subsequent slides. And weight gain. Now, weight gain is again very important, because if you have patients with comorbidities like diabetes mellitus or hypertension who are already obese, in such patients, dolutegravir can produce extreme weight gain. So that is why you have to be cautious and always document weight when the patient comes to the ART clinic. The periodic weight chart that is being maintained has to be strictly mentioned on the white folder. And reporting on serious adverse events of hyperglycemia or diabetes was limited across studies. So several studies have documented that the adverse event reporting in terms of hyperglycemia was limited. So we need long-term prospective studies which will tell us about the glycemic effects of dolutegravir. So in Brazil, about 72,000 PLHIV, 2.24% reporting of adverse drug reactions. And this is nausea, diarrhea, headache, dizziness, insomnia, drowsiness, vomiting, itching, abdominal pain, and alopecia. Out of these, 88.7% are not serious enough. 0.68% are life-threatening adverse events. 0.9% caused persistent or severe disability, and 1.4% led to hospitalization. So these are the so that is how, like, you come to know that almost 90% adverse reactions to dolutegravir are not serious. So about dolutegravir and neural tube defects, so there is potential risk of neural tube defects associated with dolutegravir use at the time of conception. So there is not a statistically significant difference when we have compared between the preconception DTG and the preconception non-DTG-RT. That means those patients who have received DTG, if you compare with the patients who have never received DTG, and you take out the incidence of neural tube defects like spina bifida. Spina bifida is a very common example of neural tube defect. And the mildest defect is, you can see a dimple at the site of the sacrum. That indicates that the neural tube has not been well formed. So this defect, we have seen that the new incidence of neural tube defects was less than 2%, 0.2%. So 0.2% is almost equal. Like if you see, even in the non-PLHIV group, it is not very significant. And other adverse pregnancy outcomes like miscarriage, stillbirth, preterm birth, low birth weight, small for gestational age, and neonatal mortality were not increased with maternal DTG compared with efavirenz containing regimens when the regimens were started pre-conception or during pregnancy. So what should be your approach? The approach should be woman-centered and a rights-based approach. Now, woman-centered means you have to focus on the woman, and it should focus on her choice, what choice she makes. And this choice is nothing but an informed choice. That means you are going to tell the woman, these are the findings out of all the studies what have happened. And this, we are starting you on a new drug which is called as dolutegravir. It has a potential to produce neural tube defects, and the incidence of which is almost similar to the other regimens what we have been giving. And so you have to make a choice. So including their sexual and reproductive health. So both the counseling have to be done at the point where she meets you. So it is not that you have to just look at the ART regimen. You also have to have comprehensive counseling of the woman of childbearing age. It is not only to be started after she becomes pregnant, but it is to be started in her reproductive life. That means whenever she gets married and she enters her reproductive phase, at that point of time she has to be offered a choice. And then once she consents to you, then you can start her on a dolutegravir based regimen. This consent can be documented by the counselor in the ART book, and then further she can be started on the dolutegravir based regimen. Now, women of childbearing age should be provided appropriate information about benefits and risks associated with the use of DTG, and medical guidance that is appropriate to her situation and supported in making informed choice. For example, say for the first baby of the woman has already had a neural tube defect, then it becomes very important that for the second subsequent pregnancy, the patient should be given an informed choice, and even if the patient consents to the dolutegravir based therapy, she should be advised that she should undergo periodic screening. That is, the fetal malformation screening should be done frequently so that these defects are not likely to be missed. If a woman plans to become pregnant, they should be counseled about the benefits of ART DTG based regimen and also the slight risk of possible neural tube defects while taking this. And alternative options such as efavirenz based regimens should also be explained to the patient. So for example, if the female says, I do not want a newer therapy, then you can just ask the patient that you can still stay on antiretroviral regimen, which can include a drug like efavirenz. So women who are already taking dolutegravir based therapy and become pregnant may continue the dolutegravir use and should be adequately counseled. And as I said, fetal malformation monitoring, the ultrasound monitoring should be done more than usual, or you can conduct maybe in concordance with the obstetrician, you can conduct several fetal scans so that anomaly is likely to be picked up early. All newly diagnosed pregnant women, irrespective of the duration of pregnancy, shall be offered dolutegravir based regimen as the preferred regimen. And all women who are pregnant and not on dolutegravir based regimen should be shifted to dolutegravir based regimen as soon as possible. So weight gain was mostly seen, dolutegravir and weight gain. So now weight gain has been mostly seen when ART backbone with tenofovir has been used. So patients who have had this combination, tenofovir, lamivudine and dolutegravir, this combination has seen the maximum weight gain. And effects of gender on weight gain appear to be ethnicity dependent with higher rates among African women. So we have seen in several studies that African women who have been started on tenofovir and dolutegravir have put on more weight than compared to men. Low CD4 and high HIV RNA were highly prognostic of the higher weight gain. And requirement of more data to better document the long-term body weight gains with DTG with and without tenofovir, including different populations and geographical regions. So we have to be very cautious, and if you find that the patient is getting excessive weight gain on this therapy, then please document it as an adverse drug reaction, so that if you increase the number of reporting, adverse drug reporting, then we can have more and more data from the centers, and we can definitely have some guidelines coming up on dolutegravir use. But if you do not report, then it will go as underreported. Renal insufficiency. So dolutegravir can reduce the tubular secretion through inhibition of OCT2, that is a receptor. OCT2 is a receptor with noticeable non-pathological and non-progressive increase in serum creatinine with no risk of renal toxicity. So for PLHIV with renal insufficiency, no dosage adjustment is required, and except on days of dialysis, dosage has to be given post-dialysis. So on dialysis day, we do not give dolutegravir, but it has to be given on after dialysis, because it is likely to be washed out during dialysis. So the whole, like if you are seeing a rise in the serum creatinine, just keep the patient on a monitor. Just frequently say, if you have done the creatinine and found it to be high, then you can repeat it after 15 days. And one should be cautious about any symptoms. So if patient starts developing uremic gastritis, that is persistent nausea, vomiting, if there is fluid overload, or if there are other signs like altered sensorium, in such patients, the cause of rise in creatinine might be a cause other than dolutegravir. And such patients, you should be very, very cautious and evaluate them in detail, and preferably such patients should be admitted. So we have till now we have not witnessed any significant rise in creatinine. Almost all the patients whom we have dealt with have developed very mild rise in creatinine. Nobody has required dialysis on dolutegravir. Hepatic insufficiency or renal insufficiency, no dose adjustment of dolutegravir is needed. And if the patient is in child PU A or B, you can use it. But if the patient is in child PU C category, that is an extreme form of hepatic insufficiency, dolutegravir should be withheld. For that, you will have to keep the child PU scoring besides you. We do not expect you to by heart it, but keep the child PU scoring card besides you so that it is handy in your clinical practice. So points to be considered while prescribing dolutegravir. Adequate counseling on lifestyle and dietary changes. So what lifestyle changes will you advocate? First is exercise. So all patients should, like say in diabetes, you advise the patient to have exercise for at least 1 hour per day. Similar thing should be advised to the patients on dolutegravir. Dietary changes, the high fat diet, high carbohydrate diet, outside food, junk food, these are all likely to aggravate the weight gain and metabolic changes that are produced by dolutegravir. So adequate water intake, keep adequate hydration. These and the lifestyle changes inclusive of mostly fruits and vegetables and high protein diet have to be advocated for all PLHIV. Measurement of blood pressure to detect hypertension with special attention to the risk of hypertension during pregnancy. Now, this is very important. In most of the ART centers, hypertension may not be detected, but no, blood pressure recording is a must. And at least during, say, if the patient has visited to twice, at least one visit you should take this blood pressure so that hypertension is diagnosed early and the impending complications are prevented. Monitoring and treating metabolic complications, glucose and lipid profile. So in the ART center, we are doing glucose and lipid profile monitoring every 3 months. So in case if the patient has some symptoms related to hyperglycemia, for example, patient has to get up several times during the night for urination, then this could be a sign of hyperglycemia. And in such patients, instead of doing glucose at 3 months interval, you have to get immediately the blood sugar fasting and postprandial level and HbA1c if it is available, so that hyperglycemia because of dolutegravir is not likely to be missed. Monitoring weight and associated complications as a part of toxicity. Now, I have already stressed on weight monitoring. So, recording of the weight as the patients come and attend the clinic, and this should be charted on the white folder so that you come to know what is the trend. And most of the centers who have data managers can equally enter the data in the Excel sheet so that any rise in the weight can be documented early. Tenofovir toxicity. Tenofovir toxicity is commonly used. Tenofovir is a commonly used antiretroviral drug which has relatively long half-life, allowing once daily dosing and making compliance easier for PLHIV. It has a good overall safety profile and few metabolic side effects and mitochondrial toxicity. Major side effects are renal toxicity and decreased bone mineral density. Now, TDF nephrotoxicity. Nephrotoxicity can lead to renal impairment. It is characterized by increase in serum creatinine. There may or may not be proteinuria. So most of the times if you do the dipstick test, in some cases it may not be positive for protein. So if proteinuria is absent, that doesn't rule out tenofovir toxicity. The patterns of kidney injury are acute kidney injury due to acute tubular necrosis, proximal tubular dysfunction, that is Fanconi syndrome. Now, Fanconi syndrome may be very difficult to diagnose. You will have to do blood sugar level at the same time and the urine dipstick test for sugar. So you have to document that the blood sugar is normal and the patient is excreting glucose in the urine. So dipstick for urine has to be positive for sugar. Hypophosphatemia, the serum phosphate level has to be estimated. Hypokalemia, hypouricemia, these two are again documented by doing blood tests, and mild metabolic acidosis, which is evident on doing a arterial blood gas analysis. And proteinuria and amino acid urea is difficult to diagnose at your end, but proteinuria you can diagnose with a simple bedside dipstick test. And chronic kidney disease can result if the patient still continues, say after developing acute tubular necrosis, if the patient is still continued on tenofovir based treatment, then it results into a chronic kidney disease. So the risk factors for development of kidney injury are elevated serum creatinine at baseline, older age, that is with every decade the rise in creatinine about 0.5 to 0.6 occurs, and this itself is a risk factor, and these elderly individuals are highly susceptible to dehydration. So because of several reasons, less water intake or concomitant conditions and use of diuretics, so especially if the patient is on say diuretic like Lasix, that is we use it for cardiac conditions, then they are more prone for developing deranged serum creatinine due to tenofovir. Diabetes mellitus itself is a condition. Diabetes and hypertension both produce nephropathy, so you have to be cautious in tenofovir use in these patients. Advanced HIV infection, low body weight, hepatitis C, concomitant use of boosted PI, concurrent use of nephrotoxic drugs. Like I have already mentioned, like if your patient is on multi-drug resistant TB and patient is on streptomycin-based therapy, then again this factor might play. Now, given the potential for nephrotoxicity, you should avoid administration of tenofovir to those with a baseline EGFR less than 60 or elevated serum creatinine. Renal function and proteinuria should be monitored during the use of tenofovir every 3 months for the first year and then every 6 monthly. Monitor the urine for protein and sugar, and more frequent monitoring may be appropriate for patients with additional kidney disease risk factors. So as I earlier mentioned, suppose if patient has renal calculi, history of renal calculi, then this renal function monitoring can be done even more frequently, like once a month or even every 15 days. Given the potential for nephrotoxicity in tenofovir treated patients who experience a confirmed GFR decline by more than 25% from baseline and to a level less than 60 ml per minute, it is recommended to substitute alternate ART drug for the tenofovir, particularly in those with evidence of tubular dysfunction. Abagavir is to be substituted for tenofovir, and lamivudine dose is adjusted as per the creatinine clearance. And if the eGFR is more than 30 ml per minute, full dose of lamivudine can be given. So most of the centers are in sort of bother whether to make the dose of lamivudine as half dose. So it is very clear that one must estimate the creatinine clearance, that is eGFR. And the creatinine clearance is calculated using the Cockcroft-Gault formula. So Cockcroft-Gault formula is already mentioned in the manual. It is also available on Medscape. You can have the Medscape software, and in that you can just enter the values, age of patient's body weight and serum creatinine, and you will get a eGFR. Full dose lamivudine can be given if the eGFR is more than 30 ml per minute. Spectrum of bone toxicity due to tenofovir. Tenofovir causes a modest bone loss as measured by bone mineral density after initiation of ART. Tenofovir was associated with a small but significant increase in fracture rate in the retrospective analysis study, and it also causes Fanconi syndrome, leading to hypophosphatemia, causing osteomalacia. So patients usually present with bone pain, and this is often neglected because patients say that they have generalized body ache. So in that way, if this is neglected, then you are likely to miss the diagnosis and resulting in severe osteomalacia and fractures. Suppose if it occurs in elderly patients, it is likely to produce a fractured neck femur, and in that patient will be disabled and bedridden. So the references for the drug toxicities are up to date. Overview of antiretroviral drugs used to treat HIV. Courtney Fletcher is the author, and is a professor of internal medicine. And there are several guidelines, like clinical practice guidelines for the management of chronic kidney disease. You can refer these and you will get the PPT very soon. You can refer to these guidelines for the references. Now, what is a proactive approach to manage the ART drug toxicities? Discuss the potential side effects with the PLHIV and the caregiver before initiation and during the early stages of treatment. Differentiate any new clinical event after the initiation of ART from IRIS. Always assess the toxicity and grade its severity, and the management of toxicity depends on the grade of severity. Offer support during minor and major adverse events. Now, what is this kind of support? The major support to the patient is hospitalization. So you have to, the ART medical officer who is treating the patient should form a link between the treating physician who is supposed to hospitalize the patient and the patient. So you have to immediately report to the consulting physician, and this patient needs referral and hospitalization with immediate effect so that the toxicity is dealt with. In grade 1 and grade 2 toxicities can be managed without hospitalization. Now, ensure that the PLHIV is familiar with the signs and symptoms of toxicities that are serious and require immediate contact with the clinical team, especially in the cases of efavirenz-associated Stevens-Johnson syndrome, hepatitis, NRTase-led lactic acidosis, or abacavir-associated hypersensitivity reaction. So it is very important that you diagnose these at an early stage. So patients mostly come to you with symptoms, and when they're hospitalized, they usually have signs. So the progression from symptoms to signs is a place where you can arrest these symptoms, and patient's condition can be reversible. So what are the possible offending agents, and what are the signs, and how do you manage? So acute hepatitis, nevirapine, efavirenz are less common. Uncommon with zidovudine. Nevirapine is the most nephrotoxic, most hepatotoxic agent. Jaundice, liver enlargement, gastrointestinal symptoms, fatigue, anorexia. Nevirapine-induced hepatitis may have hypersensitivity component. And in these drugs, you have to monitor the serum transaminases, the SGOT and SGPT, and the bilirubin. If the ALT is more than 5 times the baseline level, stop the ARV until the symptoms resolve. It should not be continued, and you have to monitor the LFTs weekly. Nevirapine should be permanently discontinued and substitute the most likely offending ARV drug. So if you know that it is nevirapine, you have to omit nevirapine and never reintroduce. If you know it is efavirenz, you can wait for the drug toxicity to subside, and then maybe after once the ALT, AST return to normal, then you can reintroduce the other drugs. Acute pancreatitis, the offending drugs are stavudine and lamivudine. Nausea, vomiting, and abdominal pain are the initial symptoms. And management is monitor the pancreatic amylase and lipase. You have to put the patient on a very low fat and low carbohydrate diet so that patients don't develop pain, because in pancreatitis, the pain is aggravated by food. So the food restrictions have to be strictly followed. So lactic acidosis, all nucleoside reverse transcriptase inhibitors, particularly stavudine. Initial symptoms are variable. A clinical prodromal syndrome may include generalized fatigue, weakness, gastrointestinal symptoms, sudden unexplained weight loss, respiratory symptoms, tachypnea and dyspnea, or neurological symptoms. Now, tachypnea, you have to actually count the respiratory rate. So if the respiratory rate goes to more than 20, it is surely indicative of tachypnea. And in this case, discontinue all antiretroviral drugs, because it is very difficult to say sometimes which particular antiretroviral drug might have caused. So usually these are all the nucleoside reverse transcriptase. Zidovudine, stavudine are most culprits in most of the times. Then give appropriate therapy. Resume ART by replacing offending ART with either abacavir or tenofovir. For hypersensitivity reactions due to abacavir and nevirapine, so as we have already discussed, what are the symptoms like rash, fever, cough, dyspnea, diarrhea. You have to discontinue all ART till the symptoms resolve. The reaction progressively worsens with frequent drug administration, so you have to stop it at immediate effect. Administer supportive therapy. Do not re-challenge with abacavir or nevirapine. Both these drugs are known to cause extremely anaphylactic reactions, and death also has been reported. So with abacavir and nevirapine, no re-challenge. Once the symptoms resolve, restart the ART with change to a different NRTA if abacavir or PI based regimen has been used. So Stevens-Johnson syndrome or toxic epidermal necrolysis, usually these affect the mucosa. So mucosal affection leads to uh, severe, say, oral rash, inability to swallow, painful swallowing. Uh, Efavirenz and rarely dolutegravir and lamivudine cause this type of rash. And the rash usually occurs within the first 2 to 4 weeks. It usually does not occur more than 4 weeks. And Stevens-Johnson syndrome can be life-threatening. In mild cases, they can be managed with antihistaminics. If rash is moderate, non-progressive, without mucosal involvement, consider substituting nevirapine to efavirenz after the rash resolves. Now, why you have to wait for the rash to resolve is because if you introduce another drug within that symptomatic period, then it might be difficult to say whether the new drug has produced the rash or the old rash has been extending. So that is why you have to wait till the rash resolves. In moderate and severe cases, discontinue all the antiretroviral drugs until symptoms resolve and give supportive treatment. Permanently discontinue nevirapine for rash with systemic symptoms such as fever, severe rash with mucosal lesions or urticaria, or Stevens-Johnson syndrome. Once resolved, switch ART regimen to a different class. So, to NRT as a PI you can take. So, discontinuing the offending drug would mean substituting with the alternative drug to ensure efficacy. So, for example, patient was on a ZLN-based therapy, then nevirapine has to be removed, and in that you have to substitute dolutegravir, which is more safer. So, zidovudine, lamivudine, dolutegravir should be the regimen. Peripheral neuropathy, it is seen as a chronic toxicity because of stavudine, pain, tingling, numbness of hands, feet, distal sensory loss, mild muscle weakness, areflexia. Stop the suspected NRTA and switch to a different one that does not have neurotoxicity. And symptoms usually resolve in 2 to 3 weeks. Diarrhea, most common offending agent is lopinavir, ritonavir, and loose or watery diarrhea is what the patient complains, and it's usually self-limited and no need to discontinue the ART. So it is this point I was referring to you. As soon say patients develop diarrhea within first or second week, if you do not call them and counsel them, this is likely to be a temporary phenomenon, and please do not give up. Otherwise, they will not come back to you. They will straight away stop the drug and just be lost to follow. So it is this counseling which is important, and the patient should be called after the symptoms subside. Dyslipidemia, insulin resistance, and hyperglycemia. Protease inhibitors and efavirenz are the most likely to be the offending agents. Consider replacing the suspected PI by drug with less risk of metabolic toxicity. Gastrointestinal intolerance, all the drugs almost they produce, and these are usually self-limited. No need to discontinue. Hematological toxicities, anemia, leukopenia are mostly because of AZT, fatigue, breathlessness, and palpitation occur. And if HB is less than 7 grams, usually 7 grams is the indication for admission. Substitute with an NRTA that has less effect on bone marrow. For example, abacavir. Lipoatrophy and lipodystrophy were seen with all NRTs, especially stavudine. We have also seen lipodystrophy because of zidovudine. So it is also the clinical sign is also called as lipodystrophy syndrome. Dyslipidemia consisting of elevated total cholesterol, low high density lipoprotein cholesterol, and elevated triglyceride. Insulin resistance with hyperglycemia. There is also central fat accumulation. You must have seen the bull neck appearance of the patient, and local fat accumulation. For example, lipomas, buffalo hump, generalized diminution of subcutaneous fat mass, that is called as lipoatrophy. You can see both lipodystrophy and lipoatrophy in the same patient. So, for example, somebody who has a bull neck appearance, that is lipodystrophy, may have retraction of the mother pad of fat, and you will see that the cheek are flattened out. So that is an example of lipodystrophy plus lipoatrophy. Then Early replacement of suspected ARV drug with TDF or ABC. Consider aesthetic treatment and physical exercise. So neuropsychiatric changes include efavirenz. So there is high risk of central nervous system. I have already mentioned those about depersonalization, nightmares, impaired concentration, abnormal dreams. Severe depression has been reported in 2.4% of cases. And as I said, suicidal ideation. So that also has to be looked into. This is usually self-limited, no need to discontinue unless severe psychosis, and counsel to take efavirenz at night before bedtime. So all the dizziness and other complaints are to the minimal. Renal toxicity or renal tubular dysfunction, you get features of Fanconi syndrome, hypophosphatemia, hypouricemia, proteinuria, normoglycemic glycosuria, acute renal failure. These are all reported. Discontinue tenofovir and give supportive treatment. After resolution, replace with another antiretroviral drug. Then rash or drug eruptions, including Steven-Johnson syndrome or toxic epidermal necrolysis. Suspecting or holding an RTM may not always be appropriate. Cotrimoxazole can be an offending agent. There are sporadic reports of skin rashes induced by zidovudine and other drugs. Essential to identify the offending drug before appropriate action is initiated. So this is the algorithm. If a patient is on tenofovir, lamivudine and DTG with cotrimoxazole prophylaxis. So in case of severe rash, stop all the antiretroviral drugs. Stop cotrimoxazole. Once the patient improves, start the ART regimen without cotrimoxazole. That is Cipline or Septran, whatever you are giving, it should not be restarted. Start only the antiretroviral regime. If it is tolerated, it is confirmed that DTG hypersensitivity is there, then you have to introduce cotrimoxazole if indicated. If rashes reappear, suspect TDF or 3TC could be the offending agent. Stop all antiretroviral drugs. Once rashes subside, give TDF plus 3TC for 7 to 10 days and observe. If rashes reappear, this is called as TL tail. Okay, the giving of tenofovir with lamivudine is called as tail of TL, TAIL, tail of TL. If rashes reappear, confirm tenofovir or lamivudine to be the offending agent and stop all the antiretroviral drugs. Once the rashes subside, give tenofovir as monotherapy 7 to 10 days and observe. If rashes reappear, confirm TDF to be the cause and start new regimen, abacavir, lamivudine and dolutegravir. If rashes do not appear, confirm 3TC to be the offending drug and start new drug regimen, tenofovir, zidovudine and dolutegravir. So in case of lamivudine toxicity, the regimen would be tenofovir, zidovudine and dolutegravir. So grading of drug toxicities, this is very important because you need to grade the drug toxicity before determining whether it requires intensive treatment, whether we can switch over back to the original drug, rechallenging of drug. That is all possible if you grade the toxicity. So antiretroviral drug toxicities can be divided into 4 grades. Grade 1 is mild, grade 2 is moderate, grade 3 is severe, and grade 4 is potentially life-threatening. Now, this clarification also includes addition of grade 5 toxicity, which is death. So, the first thing is estimating the severity. So, clinical adverse events not identified elsewhere in the table. Now, mild grade toxicity is symptoms causing minimal or no interference with the usual social and functional activities. Moderate or grade 2 is symptoms causing greater than minimal interference with usual social and functional activities. Grade 3 is symptoms causing inability to perform usual social and functional activities, and potentially life-threatening. Grade 4 is symptoms causing inability to perform basic self-care, basic medical or operative intervention indicated to prevent permanent impairment or permanent disability or death. So again, this clarification includes addition of grade 5 toxicity, which is death. So suppose if some death has occurred out of the, say, patient has developed Steven-Johnson and died, then it has to be labeled as grade 5 toxicity. So how can we now, this is a theoretical thing, but usually how these patients present mild grade 1 toxicity, there will be only rash. patient might not even have itching, or if at all itching is present, it is usually mild and which can be controlled with some lotions or some mild antihistaminics. Whereas moderate grade symptoms are symptoms causing greater than minimal itching. Patient has severe itching, patient has got high grade fever. These are the things where he's unable to go to his office, he's unable to go to his work. Then grade 3 is causing inability to perform usual social and functional activity. The patient has such high, say a patient has got severe nephrotoxicity or bone toxicity, patient is unable to get up even from the sitting position. This is a grade 3 toxicity. And a patient has say going beyond, patient is bedridden, unable to perform even basic care, that is grade 4 toxicity. So you have to grade the toxicity appropriately. Now again, this is the chart where we have already discussed. Of grade 1 toxicity, the changes of ART should be avoided. You should just observe. Then again, grade 2 also, changes should be avoided and you should observe, and you should give symptomatic treatment. In both these cases, symptomatic like antihistaminic or anti-allergic treatment, you have to initiate. Now grade 3 toxicity, it is necessary that the drug to be discontinued, and it may be possible in future to cautiously re-administer the drug under close monitoring. For example, we have done this type of monitoring in the wards. For example, we have done it for lamivudine toxicity, and we have done gradual reintroduction, and it has been made possible. And potentially life-threatening, discontinue all the drugs, hospitalize the patient. Offending drug should not be re-administered. After improvement, institute the alternate and ART regimen comprising of a drug substituted for the offending drug. So, and as I said earlier, in case of abacavir and in case of nevirapine, you should never re-challenge the patient. So laboratory grading, we also, as we have already discussed the clinical grading, we have also the laboratory grading. The parameters used are hemoglobin, absolute neutrophil count, platelets, hyperbilirubinemia, glucose, hypoglycemia, and hyperglycemia. These are the grades which have been mentioned, and you can. No, I am not expecting any of the participants to by heart or thoroughly remember this chart, but you should have this printout ready in your clinical setting, because as soon as a patient attends your OPD or your ART center, you should have this chart handy besides you, and you can easily from this table mark the drug toxicity. So if the patient, say example, a patient on zidovudine therapy has developed a hemoglobin of say 7.5 grams. So 7.5 grams will fall into grade 2 toxicity. So you have to label that as a grade 2 toxicity, and then you have to give the patient some iron preparations, multivitamins, and maybe call the patient for follow-up. If the repeat hemoglobin also shows a drop, then stop the drug. So this is again the toxicity. This is elevation in terms of, say, for example, more than 1 to 1.5 times the upper limit of normal. ULN is nothing but the upper limit of normal. This upper limit of normal may be variable for different laboratories, and you have to use your laboratory reference ranges. Do not use, say, suppose your lab has provided a report of creatinine of 3, or say it has provided a creatinine of 1.8. Then you use your own laboratory reference range. Do not use other laboratory reference range to label the toxicity. Now about the gastrointestinal side effects, how to manage them. So nausea, if it is mild or grade 1 toxicity, then it is reasonable, intake is maintained. You just have to observe. Then you have a moderate discomfort or decreased intake of food less than 3 days. You have a discomfort or minimal intake of more than 3 days, and potentially life-threatening is hospitalization. Again, similar for vomiting, you have whether it is mild or whether it is moderate or severe with dehydration or static hypotension or hypertensive shock, I think is wrongly printed here. It should be hypotensive shock or hospitalization for intravenous treatment. And again, diarrhea, it should be hypotensive shock or hospitalization. So respiratory and urine related, you will have to see for dyspnea, whether dyspnea is on exertion, whether normal activity at rest, and dyspnea requiring oxygen therapy. These are the 4 grades. And for urine analysis, you have to do the spot urine, 24 hours urine, and gross hematuria. So whether blood cells, red blood cells are seen in the urine, you have to grade accordingly. And this is grading of selected clinical features and toxicities. So headache, allergic reaction, rash, hypersensitivity, fatigue, you have to grade according to this chart. Now drug substitution. Drug substitution is the replacement of ARV drugs in PLHIV due to adverse effects. That is drug-to-drug interaction or program policy. It does not indicate change of regimen due to treatment failure. So when you are substituting one drug, it should be written as alternate line. You do not have to say that it is treatment failure. If you make a switch, then it indicates a treatment failure. Then you will have to document as first line failure or second line failure. When drug interruptions are required, such as for severe and life-threatening adverse events, it is important to consider various half-lives of the drugs. So, for example, when NNRTI needs to be discontinued, a staggered approach should be followed, in which the use of NRTI backbone is prolonged for 2 to 3 weeks. Alternatively, it can be temporarily replaced with a protease inhibitor. Now, drug interruption, the general principle is single drug substitution for toxicity should be made with the same ARV class. If severe or life-threatening toxicity, ART should be stopped until the symptoms subside or the signs resolve. Whenever the ARV toxicity is suspected, rule out otherwise or other conditions that may be responsible. And for patients with dual toxicity to nevirapine and efavirenz needing substitution with protease inhibitors, these regimens must be started by the Center of Excellence, that is ART plus center, after the review and approval of ESASEP. Because we always document the PI based therapy as whether it is alternate first line or it is a change of regimen. So for zidovudine toxicity, suggested first line is tenofovir. For abacavir, it is tenofovir or zidovudine if tenofovir is contraindicated. Tenofovir toxicity should be the suggested first line ARVs abacavir. For efavirenz, it is dolutegravir. So if there is toxicity to both efavirenz and nevirapine, it should be substituted with dolutegravir. If dolutegravir itself has toxicity, then efavirenz based regimen with appropriate 2 NRDS has to be substituted. Atazanavir, ritonavir, and lopinavir, ritonavir, both toxicities has to be substituted with DTG, and multiple NRTS, DTG in combination with appropriate boosted PIs. For hepatotoxicity or hypersensitivity reactions, co-infection with hepatitis B or C, substitute another therapeutic class, efavirenz or boosted PI. Insomnia, older than 60 years, consider monitoring dose or substitute efavirenz, boosted PI or dolutegravir. And for weight gain, older than 60 years, monitor the body weight and promote anti-obesity measures such as diet and physical exercise. Then low CD4 count or high viral load, and in female patients, significant increase despite measures, consider substituting efavirenz or boosted PI. So drug substitution for impaired renal function is abacavir, lamivudine, and dolutegravir, with dose adjustment of lamivudine according to creatinine clearance. So for example, if creatinine clearance is more than 30, full dose of abacavir with lamivudine 300 mg can be given. For patients with clearance less than 30, if lamivudine 100 tablet is not available, full dose tablet of abacavir 600 plus lamivudine 300 with close monitoring of renal functions, and you should repeatedly do the renal function test. So thank you. So if there are any queries, I can answer them.
Thank you so much, ma'am. Ma'am, we have a question in the chat box. In cases on TLD adverse effects, weight gain is noticed. Is there any limit of weight gain for changing ART regimen?
Yes,
Is there
as of now, there is no limit being, but you have to assess if the patient has comorbidities. For example, if the patient has diabetes mellitus and he is gaining weight, and also it is associated with impaired sugar glucose control, then this weight gain is quite is causing impairment in the glycemic status, and or patient presents with new cardiac symptoms of cardiac ischemia, then definitely this is an indication which you have to consider changing a regimen, but otherwise not. There are no specific guidelines at 5 kg or 10 kg you should you have to monitor and you have to assess the comorbidities. That is very important.
Thank you, ma'am. Any questions from the participants? Please feel free to unmute.
Hello.
Yes, sir.
Yes.
Madam, patient with TLD having higher sugar level, in such patient, if you are giving metformin, but dose of metformin is we should not exceed 1 gram. So
Yes.
in such patient, which is the drug of choice for such patient where there is a hyperglycemia?
Yeah, so
TLD
we can use glimepiride. We can initiate a second drug like glimepiride or glipizide, or you have several now. Now the only problem you can have is with drugs like sitagliptin, because then you have to monitor for pancreatitis also. So the diabetes management should be optimum, and you can increase the drug doses, existing drug dose, or you can introduce one new drug.
Achha. Okay, madam. Thank you.
Any more questions from the participants? You can also write in the chat box. Ma'am, I don't think there are any questions. Can we quickly run the feedback form, please? Thank you. The feedback form is now visible on your screen. There are 4 questions in all. Please attempt all the 4 questions. Kiran sir, we can end the feedback poll. Thank you, Sonali ma'am, for facilitating this session.
Thank you very much.
Thank you to all the participants for patient listening. We'll have the next session in the next week. We'll keep you informed. Thank you. We can end the session now.
Yeah.